Management of pseudopancreatic cyst. A pseudopancreatic cyst is a localized collection of pancreatic fluid, usually surrounded by a fibrous or granulation tissue wall, resulting from acute or chronic pancreatitis. These cysts lack an epithelial lining, distinguishing them from true pancreatic cysts. Management strategies have evolved with advances in endoscopic, radiological, and surgical techniques. Traditional management approaches. 1. Conservative management. Indications: small cysts 6 centimeters that are asymptomatic and not infected. Approach: observation with regular follow-up imaging, ultrasound, CT, or MRI. Supportive care, including pancreatic enzyme supplements and dietary modifications. Pain management. Outcomes: most small pseudocysts resolve spontaneously. 2. Percutaneous drainage. Indications: symptomatic pseudocysts, those at risk of rupture, or infected cysts in patients who are not candidates for surgery. Technique: ultrasound or CT guided placement of a drainage catheter. Drainage analyzed for infection or malignancy. Risks: external fistula formation, incomplete drainage, or recurrence. 3. Surgical drainage. Indications: large symptomatic cysts, recurrent or complicated pseudocysts, failure of conservative and percutaneous methods. Techniques: cystogastrostomy, connection between the cyst and stomach. Cystojejunostomy, anastomosis between the cyst and the junum. Cystoduodenostomy, connecting the cyst to the duodenum. Advantages: definitive treatment with minimal recurrence. Risks: operative morbidity and prolonged recovery. Recent advances in management. 1. Endoscopic management. Endoscopic interventions have become the preferred approach for many pseudopancreatic cysts due to their minimally invasive nature. Key techniques include endoscopic ultrasound-guided drainage, EUS-GD, procedure, using EUS to visualize the cyst and place stents or perform drainage. Tools: double pigtail stents, lumen-opposing metal stents, LAMs, or nasocystic drainage catheters. Advantages: real-time visualization reduces complications. Can handle cysts in difficult anatomical locations. Lower morbidity than surgery. Cystogastrostomy or cystoduodenostomy with stenting, indicated for cysts adherent to the stomach or duodenum. LAMs are increasingly favored for their wide lumen and ease of placement, combined with balloon dilation if the cyst has thick debris or necrosis. 2. Advanced imaging techniques. MRI and EUS provide better characterization of pseudocysts. EUS-guided fine needle aspiration, FNA, helps distinguish pseudocysts from neoplastic cystic lesions. 3. Minimally invasive surgical techniques. Laparoscopic drainage, a less invasive alternative to open surgery. Benefits: reduced postoperative pain, shorter hospital stays, and faster recovery. 4. Management of infected pseudocysts. Use of antibiotics tailored to culture results. Drainage guided by imaging or EUS. Combined necrosectomy for pseudocysts with walled-off necrosis. 5. Hybrid techniques. Integration of percutaneous, endoscopic, and laparoscopic methods for complex or multiloculated cysts. Example: initial percutaneous drainage followed by endoscopic stenting. Recent innovations. 1. Lumen-opposing metal stents. Revolutionized endoscopic management. Self-expanding stents with wide lumens allow simultaneous drainage of cyst fluid and necrotic material, associated with fewer complications and high success rates. 2. Endoscopic vacuum-assisted drainage, useful for cysts with walled-off necrosis. Vacuum-assisted closure systems help clean the cavity over time. 3. Biodegradable stents. Avoid the need for a second procedure to remove the stent. Early trials show promising results. 4. Robotics in surgery. Robotic platforms offer better visualization and precision during minimally invasive surgical drainage. 5. Therapeutic drug delivery. Trials with enzyme-based solutions for enzymatic debridement of pseudocysts. Choice of management. Management is individualized based on size, location, and complexity of the pseudocyst, presence of symptoms, e.g., pain, infection, obstruction, patient comorbidities and preference, institutional expertise in endoscopic and surgical techniques. Conclusion: the management of pseudopancreatic cysts has shifted towards less invasive approaches, with endoscopic techniques playing a dominant role. Recent advances such as LAMs, hybrid techniques, and robotics have improved outcomes and reduced morbidity. Future innovations in stent technology and drug delivery systems hold promise for further refining treatment.